Good afternoon. Welcome everyone to Orientation to Agricultural Worker Health, presented by the National Center for Farmworker Health in collaboration with the Ag Worker Access Campaign Task Force. Today, we're going to be covering 3 different learning objectives, and our hope is that by the end of our time together, you will have a foundational understanding of agricultural worker health and the unique factors that impact this population and their access to healthcare. So understanding how a migrant health program functions and is funded and the services provided to the ag worker population. Our second learning objective, identify ag worker demographics and discuss how demographics and culture of the population impact healthcare access. And identify unique challenges and barriers faced by the ag worker population. For those of you who may not be familiar with NCFH, we are a private nonprofit organization located outside of Austin in Buda, Texas. Our mission is to improve the health of farm worker families. And we do this by providing programs, trainings, and technical assistance and resources. We celebrated our 45th anniversary in 2020, and we are very proud to be able to serve the 177 community and migrant health centers in our network, who provide primary care services to agricultural worker families. And today, as I mentioned, we are presenting in collaboration with the Ag Worker Access Campaign Task Force. And these are our task force supporting organizations. We are grateful to all the work that they do in supporting the campaign and the campaign's mission and guiding our Ag Worker Access campaign. The Ag Worker Access campaign was launched in 2015 as a joint effort by the National Center for Farmworker Health and the National Association of Community Health Centers, NAC. We, along with health center staff and other ag worker advocates, knew that more could be done to increase access to quality healthcare for America's agricultural workers and their families. The result was the Ag Worker Access campaign. We've seen steady increases in the number of ag workers served in health centers since the campaign's launch in 2015, with the 2019 UDS data showing we surpassed our halfway milestone of 1 million ag workers served. In 2020, there was a decline in the number of ag workers served, likely due to the impacts health centers and ag workers experienced because of COVID-19. But we are excited to share that we have once again surpassed our halfway milestone of 1 million ag workers served, as seen in the 2021 UDS data. And we are confident in the hard work and determination of health centers across the country that we will continue growing from here. So to get us started, in order to understand the Migrant Health Program, when and why it began, it's important to take a look at the history that led to the program. So the US has been importing agricultural workers for a very long time. From our nation's creation, agriculture and the small family farmer were considered essential components of our democracy. Starting in the 1850s, there were major advances in crop production, and crop production was growing larger and larger. As crop production grew, wars caused labor shortages to work the fields, and the demand for immigrant labor continued into 1917 when the US entered World War I. In response to this, Congress passed the Immigration and Nationality Act of 1917, which established a legal basis for the importation of 70,000 workers from Mexico. This was the first guest worker program in the US. Then again, when the US entered World War II, commercial farmers faced a high demand for their products without sufficient labor. And the US called on Mexico once again to fill this labor void through the establishment of the Bracero Act, which was the largest guest worker program to date. Although the Bracero Act was devised to meet the World War II shortages, the program continued until 1964, ultimately employing 5 million Mexican laborers. In 1952, the H-2 program was established. This program is similar to the Bracero, but requires certification of labor shortage to legally import workers. This program is still in existence today as the H-2A program. By 1962, many ag workers in the fields were experiencing harsh conditions, low pay, and little access to care. President John F. Kennedy signed the Migrant Health Act, also known as the Public Health Act, which authorized funds to create a small number of migrant health centers to provide preventative and primary healthcare services to the ag worker population. Initially, the Migrant Health Center served only agricultural workers and therefore operated only during the agricultural seasons. This created a community sentiment of preferential treatment to agricultural workers within the communities where these centers were located, and the community members expressed their dissatisfaction and how they wanted to have access to these health centers as well. In response, the federal government made money available to health centers already receiving migrant dollars to jointly serve the community at large under Section 330 of the Public Health Services Act. This meant that health centers receiving federal assistance under Sections 329 and 330 were under obligation to provide services to both migratory agricultural workers and the community as a whole. Although some health centers have done an excellent job at maintaining their focus of serving both populations, others have been overwhelmed and challenged to maintain that level of focus in reaching the agricultural worker community. This problem is further aggravated by the limited resources available to provide outreach, translation, transportation, and other enabling services needed to serve the hard-to-reach agricultural worker population. So in 1996, Congress approved the Health Center Consolidation Act. This act authorized the consolidation of migrant, community, home, and homeless sections of the Public Health Act under the umbrella of 330 programs. Under this consolidation, migrant health money was integrated into community health funding and expanded its reach to include aged and disabled agricultural workers. Section 330 of the Public Health Service Act defines the Health Center program as a funding opportunity for organizations to provide healthcare to underserved populations. So with the Consolidation Act, definitions were created for health center programs to define agriculture and also the three classifications of agricultural workers. So the term agriculture means farming in all of its branches. It involves everything from prepping the soil to seeding, planting, growing, picking, packing, to transporting. It includes crop production, animal production, and aquaculture support activities. There are three classifications of agricultural workers for migrant health programs: migratory agricultural workers, seasonal agricultural workers, and our aged and disabled former migratory agricultural workers. Migratory agricultural workers, their principal employment is in agriculture. They've been employed within the last 24 months or 2 years, and they establish a temporary home for the purposes of working in agriculture. Our seasonal agricultural workers are defined as also a principal employment in agriculture on a seasonal basis and employed within the last 24 months or 2 years. And they're not migratory because they do not have to establish a temporary home in order to work in agriculture. And our third classification are aged and disabled. These are former migratory agricultural workers that are unable to work in agriculture due to age or disability. All community health centers are required to identify and classify their vulnerable populations, which includes our migratory and seasonal agricultural workers. Also, identifying and classifying these patients helps to provide clinical treatment and a plan for continuity of care, as they may be in your area for only a short period of time. So a great way to start with understanding the agriculture worker population, in addition to the history, is to take a look at the most recent demographic information on the population. The data that we'll be sharing in this next section comes from the National Agricultural Worker Survey, or NAWS, and it provides data on demographics, employment, and health characteristics. The survey is conducted annually and is a random field survey, although the results are not published every year. So the data we're sharing is from the 2017-2018 survey. And there's a link coming through the chat to a fact sheet where NCFH has summarized some of the key statistics from this survey. So looking at some general demographics, the average agricultural worker is 41 years old, with 67% of ag workers falling between ages 25 and 54. So about 1/3 of ag workers are younger than 35. 66% of ag workers are male and 34% are female. With ethnicity and race, 77% of ag workers identify as Hispanic. Among US-born workers, 30% self-identify as Hispanic. More than half of ag workers are married, about 57%, and half of ag workers are also parents. Looking at income, 20% of ag workers earn below the poverty line, which is an annual income of less than $30,000. Looking at education, the average educational attainment is 9th grade among the population. 35% completed 6th grade or lower. 31% complete grades 10, 11, or 12, and 12% complete some education beyond high school. Looking at a key demographic, language, Spanish and English are the primary languages reported in this population. 62% of ag workers prefer Spanish as their speaking language, to 27% who prefer English. And among workers born in Mexico or Central America, nearly all reported Spanish as their primary language at 93%. And although Spanish and English are the primary languages among the population, we do know that there are other languages spoken among ag worker populations and communities, such as Indigenous languages and Haitian Creole. Looking at healthcare utilization, 71% of ag workers used healthcare services in the US in the last 2 years. 26% paid for these services out of pocket, 16% paid using personal or family insurance plans, 24% used Medicaid or Medicare, and 11% were not charged for their visit. When it comes to employment, agricultural work is not steady. We know it's dependent on season, weather, and market demands. So year-round work is not always possible due to the nature of agriculture. Agricultural workers are typically employed by the growers or packing firms directly, roughly 89%, and a small percentage, 11%, are employed by labor contractors. Workers may not be employed in agriculture when they seek care at a health center, but they can still be identified as agricultural workers if they've been employed in agriculture anytime in the last 24 months or 2 years, as we learned about in those classification definitions. Looking at working hours, agricultural workers' hours accommodate the crops, not vice versa. So there are several different payment methods and working hour situations. 42% of ag workers report working more than 8 hours a day. On average, workers work 35 weeks of the year in agriculture, 6 weeks doing non-agriculture work, and 9 weeks unemployed in the United States, and an average of 2 weeks per year outside of the US. Looking at migration patterns, 13% of ag workers are migratory, and 85% of ag workers are seasonal. Of those migratory workers, 47% were domestic or US-based, 42% were international, and 11% had been in the US less than a year. Looking at work type, 28% work in fruits and nuts, 20% work in vegetables, and 24% work in horticulture. The migratory agricultural workers were less likely than seasonal workers to hold a job in horticulture. And looking at housing, 30% have reported living in crowded dwellings where more than one worker shares the same room, and 14% live on the farm of their current employer. Looking a little bit deeper into migration trends and traditional patterns of mobility, there are 3 main streams of migration as seen on this map. They are the Western, Midwestern, and Eastern. California, Texas, and Florida are starting spots of migration with their designated streams and sometimes move in different directions across the United States. There are three traditional patterns of mobility. The first is restricted circuit mobility. These ag workers follow crops in one area and are centered around a home base. They move to work, but they come home frequently. And these are our seasonal workers. 87% of ag workers are seasonal, and they work within roughly 75 miles from home. There's a lot less trans-border crossing in this population and more workers engaged in other industries in the off-season. There's also point-to-point mobility. These ag workers move away from home base for extended periods of time, and they often go back to the same location multiple years in a row. And often a whole family travels together. And these are our migratory agricultural workers. The number of migratory workers has decreased over the years and is now roughly 13%. One thing to note is that this NAS data does not include H-2A workers, but we know H-2A workers are all migratory and account for about 10 to 15% of the agriculture workforce nationally. Our third pattern of mobility is nomadic. These ag workers travel to wherever there is work. They usually do not know when or to where they will move next. And they're typically foreign-born young single men. And there's been an increase in this pattern of mobility due to the increase in H-2A workers across the country. So next, we're going to look at working and housing conditions. As we know, agricultural work fluctuates. It depends on season, weather, and market demands, as we already discussed. Hours can be extended from early morning to late in the evening and done every day versus 5 days a week. Income is also unique. There are several different ways of receiving income for ag workers. Some are paid by the hour, some are paid by the piece picked, and some are paid with salary. 86% of ag worker households reported not receiving a benefit of a needs-based program in the past 2 years. So the majority of ag workers do not receive any type of benefits. Looking at housing conditions, adequate, affordable, and safe housing has been and continues to be a constant struggle for migratory and seasonal agricultural workers. There are several ways that ag workers have and receive housing. A small 14% of ag workers may have housing provided by their employer. This is often the case for migratory workers, given that they travel for work and traditionally is met by growers through the establishment of labor camps. Employers recognize that the lack of housing is a serious issue, but they face several disincentives to providing housing for their migratory workers. Given construction and maintenance of this housing can be expensive, especially if it's only going to be occupied during a short harvest season. This often results in substandard housing. However, most ag workers do not have housing provided by their employers and need to find their own housing. Nationally, 50% of workers report renting property for housing. However, most communities may not have enough rental units available, or they may be unavailable to ag workers because they cannot provide deposits, qualify in credit checks, or make long-term rental commitments due to their migratory travel. Therefore, ag workers struggle to find places to live, especially in rural areas where housing is already limited. Some end up sharing rental properties with others who work on the same farm to make it more affordable. However, much of the housing available is deficient, crowded, and unsanitary. So this can add to their health risks. Some ag workers have their own private housing. This is about 35% of the population, and this is usually the case for our seasonal workers. Private housing is not subject to federal regulation. Therefore, whatever is available to ag workers tends to be substandard and many times very expensive. So we will see workers living together under these conditions with family and relatives, which again creates a crowded living environment. In the absence of housing, ag workers may be forced to sleep in tents, cars, ditches, or open fields. We know the migratory labor force is very important to the agricultural sector, which in turn is an important part of the overall local economy. So it's clear that steps need to be taken to help our migratory agricultural workers and agricultural workers at large find solutions to their housing needs. As mentioned, much of the housing available is deficient, crowded, and unsanitary, and this leads to some health risks. Some of the common illnesses related to housing we often see are UTIs and intestinal parasites, GI issues, skin conditions, respiratory conditions, and infectious diseases. With crowded housing, it makes it difficult to practice those social distancing and quarantine recommendations that we've become familiar with over the past few years, which increases the risk for transmission of COVID-19, as well as other infectious diseases such as the flu, tuberculosis, and other viruses. So next, we're going to talk about some of the occupational risks related to agricultural work. Agricultural work is consistently ranked as one of the top 3 most dangerous occupations in the US. In 2020, 368 agricultural workers died of work-related injuries. Our immigrant workers are often most vulnerable to occupational risks, such as labor trafficking, where an employer may control the movement of their workers through threats, debt bondage, or other means. Agriculture has the second highest number of reported labor trafficking cases in the US. Many of the occupational injuries that workers face are related to the specific type of work that they do, such as musculoskeletal injuries and disorders like carpal tunnel, shoulder injuries, sprains and strains, lower back pain. The repetitive motions and heavy lifting can cause pain, arthritis, and other problems. Many of the motions that agricultural workers do that contribute to these ailments are stooping, picking, carrying heavy things, lifting, using heavy equipment, packing, and even falls from ladders and other equipment. Other risks relate to the way that agricultural work is set up in general. Due to being outside all day, weather plays a major role and can contribute to heat stress and dehydration. Ag workers are also at risk of insect, rodent, and snake bites. The percentage of piece rate wages versus hourly wages, the practice of piece rate wages, encourages people to work longer, harder, and faster without taking breaks in order to earn more income. So beyond the expected physical impact of this practice, it also contributes to workers not taking the time to take care of themselves while working. So not taking a break to meet their just most general needs, or taking a break for medical appointments, which can lead to the lack of management of chronic health conditions and other issues. Additionally, vehicle accidents are a large problem amongst migratory workers, given that they are often transported to and from work by their crew leaders in unsafe vehicles that may not have seatbelts or can be overcrowded. Also, due to migrating, the opportunity for accidents on the road while traveling to their next destination makes their risk of car accidents higher than the general population. In addition to the housing risks that lead to the spread of COVID-19, also at work, lack of safety precautions implemented in the workplace, not using social distancing, lack of personal protective equipment, lack of hand washing stations, and the inability to quarantine can lead to high transmission of COVID-19 in the workplace. Also, agricultural workers were deemed essential workers throughout pandemic, which also increased the transmission for this population. This slide highlights some of the problems associated with field sanitation, pesticide exposure, and the environmental risks associated with agricultural work. Agricultural work often requires, as we discussed stooping, climbing, carrying heavy loads, working with the soil, and direct contact with plants. This direct contact with plants puts them at risk for exposure to pesticides, chemical fertilizers that are used for cultivating the plants. There are some plants, such as tobacco and strawberries, that release chemicals that can be toxic to humans and can cause severe allergic reactions, such as contact dermatitis. In addition, there are reports of workers resorting to irrigation ditches and runoff ponds when safe water is not available for drinking and hand washing. Exposure to the pesticides and chemical fertilizers and organic waste that are contaminating this water can lead to some serious illnesses, including conjunctivitis, intestinal illness, risk for cancer, and other neurological disorders as well. Some of these disorders can be misdiagnosed, given that some of the symptoms are common to other things. So it's important that your health centers and staff are aware and providers are aware of these exposures so that these issues and illnesses can be properly diagnosed. The EPA estimates between 10 and 20,000 poisoned agricultural workers per year. The exposure to these pesticides and chemicals also puts their family members at risk as well, due to the residue that can be left on their skin and clothing and shoes that they may bring home from work at the end of the day. So to address some of these occupational and environmental risks, there are 3 regulations that have been put into place specific to agricultural workers. The Department of Labor put into place the Migrant and Seasonal Agricultural Worker Protection Act in 1983, which established the rights of ag workers and the guidelines labor contractors must follow. The second is the Field Sanitation Standard of 1987, which OSHA put into place. It applies in all states and requires the availability of safe drinking water and sanitary toilet facilities. These regulations will require agricultural employers of 11 or more workers to provide drinking water, hand washing facilities, and toilets for their employees. However, farms with 10 or fewer employees are exempt from these requirements. The intention of this exemption was to avoid placing an unnecessary financial burden on small farms. However, as a result, these very basic amenities are not required by law for many agricultural workers, regardless of the conditions or hours required of them by their work. The third regulation is the Worker Protection Standard of 1992 from the Environmental Protection Agency. This is a federal regulation designed to reduce pesticide poisoning by requiring safety training, notification of pesticide application, the use of personal protective equipment, restricted entry after application of contaminants and pesticides, and emergency medical assistance. It is important to remember that the enforcement of these regulations is dependent on the size of the farm and the entity in charge of enforcement in the area. Agricultural workers are also excluded from many labor rights. For example, the right to organize and bargain collectively under the National Labor Relations Act. They are also not entitled to overtime pay under the Fair Labor Standards Act, with the exception of California in 2016. And they are also only covered by 7 of the Occupational Safety and Health Administration standards. There have been some improvements in certain states, for example, California. As I mentioned, in 2016, they introduced a bill that would expand when ag workers are entitled to better overtime pay. They were the first and only state in the nation to grant overtime pay to agricultural workers. Their governor also signed a landmark agreement that gave ag workers the right to organize. However, this is not the case in many other states. So this means that agricultural workers have less protections than most other labor groups and are at greater risk for illegal and unfair treatment, injuries and unhealthy conditions, scams, and many other risks. So now that we have an understanding of some of the general characteristics and demographics of the population, we know about some of the housing and employment conditions and occupational hazards, some of the protections and lack of protections that ag workers receive. We're going to move into talking about what medical conditions are commonly experienced, as well as what are those barriers to accessing healthcare for the population. So research indicates that agricultural workers have lower rates of many chronic diseases compared to the general population. But a lack of access to healthcare may mean that they have many undiagnosed health conditions. Common chronic conditions within the population include diabetes, obesity, hypertension, and chronic respiratory and musculoskeletal disorders. The primary challenge for an ag worker patient with a chronic disease, especially one who migrates, is continuity of care and self-management of their chronic condition. Mental health is also a concern among agricultural workers. Factors that impact mental health within the population are traveling alone, being separated from family, and that lack of family support can be very difficult. Additionally, agricultural working parents who have children who have little access to childcare or lack access to education and nutrition programs to their children can put a lot of stress on a family. Additionally, food insecurity is a large issue that can lead to mental health issues. We saw in COVID-19 that food banks were experiencing a very increased demand, which put stress on many communities, including the agricultural worker community. Agricultural workers may also be reluctant to talk about mental health issues due to cultural barriers and stigma. We've touched on a lot of the barriers to care throughout the presentation, but there are individual and systems level barriers for agricultural workers in accessing healthcare. Mobility and long days often threaten their health and pose a significant barrier to accessing healthcare. As we previously noted, many agricultural workers have total family incomes below the federal poverty level, which makes finances a big factor in accessing care as well. This puts a worker in the predicament of having to choose between paying for healthcare and meeting their essential needs. Many workers do not have health insurance, which forces them to seek medical care only when absolutely necessary, which means preventative care may not be a priority. Because of the limited benefits that ag workers receive, sick leave is rarely an option. So workers do not take time off of work to take care of their healthcare needs for fear of losing their job or losing that income. Additionally, one of the most commonly reported individual barriers to care is language. As we noted, 65% of workers cited Spanish as their native language and their preferred language. Therefore, the inability to speak English fluently or comfortably can pose a great barrier in their healthcare access. Many workers additionally have low levels of literacy, which can increase those barriers to accessing and understanding healthcare. Workers are often unfamiliar with the US healthcare system additionally, which can be really difficult to navigate and become familiar with. Additionally, lack of transportation is a big barrier, with rural areas not having a public transit system. Transportation can be a huge barrier to accessing care. Looking at the systems level barriers, there are labor policies that don't include that paid sick leave and time off. There are community and workplace barriers. Limited healthcare sites available in rural areas, immigration systems and threats of deportation at the systems level, exclusion from public and private health insurance, and just that lack of awareness about the agricultural worker community and their challenges among the public health officials and healthcare providers can also create a barrier at the systems level. So now we're going to talk about the Migrant Health Program and service delivery. How are all these health services delivered to the agricultural worker population? Migrant health centers must provide services required by the Migrant Health Program. Grantees receive federal funding from the Public Health Service Act, Section 330, to provide services for people in the community, specifically for migratory and seasonal agricultural workers. Although the size and the extent of the services varies by health center, the majority do provide comprehensive care within their networks, although it's not uncommon to have health centers that offer basic on-site services and then refer patients out to a larger clinic within their network for additional services. As a rule of thumb, the larger the budget at the center, the more comprehensive the services are that the health center can offer. But at a minimum, these are the wide range of diagnostic and support services that the federal government requires: primary care services, preventative, emergency, pharmacy, and ancillary. So now we have a very special part of our presentation where our co-presenter Lucrecia Castaneda, the Community Programs Coordinator at Adelante Healthcare in Arizona. She is a member of the Ag Worker Access Campaign Task Force and is going to be sharing a patient experience where she was able to offer outreach and enabling services to an agricultural worker to help them gain access to the healthcare that they needed. So I'm going to pass it over to you.
Hello, everyone. Can everyone hear me? Not sure.
Yes.
Okay. Today, I want to talk to you about a mission moment that we had with one of our H2A farm workers. So as part of our outreach, we partner with many organizations that provide services to farm workers, one of which is Arizona at Work, which is our state liaisons for H2A workers. When they go out to provide mid-contract checkups to the farms, or when they do their orientations, they invite us to come and talk about our services to the farm workers. So they have a place to call when they don't feel well. We had a situation one day where Arizona at Work called us that one of the farmers they were working with had reached out to them regarding an H2A worker who was not feeling well. The farm worker had already gone to the hospital a few times and incurred a significant amount of expenses since he was uninsured. When we had a situation one day, we were able to go to the farm and talk to all the farm workers about our services, but we connected with the farm worker that was not feeling well and were able to talk about healthcare options for him. We found out that he had applied for emergency Medicaid, but he was not familiar with the program and did not know how to follow up. As a CHW, we are trained to submit Medicaid applications and verify what applications have been submitted for a patient. Therefore, we utilize this tool to verify if his application was submitted and find out if any documents were still pending. With this worker, we found out that he was approved for emergency Medicaid so that his hospital bills could be covered. He was referred to a cardiologist from the hospital, which is a service our health center does not offer. Therefore, we refer him to a local FQAC that offers specialty services under a sliding fee scale program. However, because he was desperate to be seen quickly, he declined and saw a cardiologist and paid full price. 2 days after he saw the cardiologist, we follow up with him to make sure he was okay. And he informed us that he told us that he was told by the specialist that he did not have a heart issue. But the provider didn't really give him any other information as to why he was still feeling sick. When we then enroll him into our sliding fee scale program and schedule him a primary care appointment at one of our facilities. Once he saw our providers, our care coordinator did an assessment and determined he needed to be seen by our behavioral health team. We were able to schedule him on the same day as his primary care appointment. Our team was able to assess that his symptoms stem from depression and were not heart related. They scheduled him to see our behavioral health team on a weekly basis and either virtual or in person, depending on his availability. We continue to follow up with him and he's doing very well now. Since he's an H-2A worker, he is scheduled to go back home with this month. However, we plan to follow up to continue to check on him, and he has all our contact information so that when he returns next year, he can continue his care with us. We try to make it a little more personal with our workers by calling them after their appointments and just asking how they feel, if they have any questions, or letting them know how we can help, and giving them options to contact us with any questions or if it's just something they didn't understand at their appointments. We found out that by doing this, they are more put into calling us when they come back for another season, and they promote us with other workers that are more hesitant. Most of the workers will come back for another season to the same farm, but a couple of them might move to another farm and keep our contact information and call us when they come back. And by doing this, allowing us to create a new contact with a different farm. All of our sites provide transportation, interpretation, and translation services to our patients, including our farm workers. This is our sample of how we utilize our outreach enabling services. We are able to make a difference in the lives of our farm workers and patients we serve. Do anybody has any questions, anybody?
I don't see any in the chat.
No.
But feel free to put your questions in the chat and we can answer them. We also will have Lucretia available at the Q&A section of the webinar later in just a little bit.
Thank you. And this is just one of our mission moments that we had with that farm.
Thank you so much, Lucretia. That was such a wonderful example of your outreach and enabling services. I think you could check nearly every enabling service on the slide right now through that example. So thank you so much for sharing that and for all the hard work that you all are doing to serve the ag worker population and your support to the campaign and the task force.
Thank you.
So we recognize that there are service delivery challenges and other systems barriers that can stand in the way of providing these great outreach and enabling services. There are three main organizational systems that we think lead to overcoming those barriers and are essential to have in place within your organizations. And these include policies, procedures, and training. So there's many things to consider when addressing these challenges, but some things to ask yourself are, how long are your wait times? Do you need more capacity or training? What are your hours of operation? Are they hours that can serve the ag worker population? Do you have a training protocol in place for staff to learn about ag workers and ag worker identification? And do you have continuing education available for staff around cultural and language, customer service, etc.? So as Lucretia mentioned, she touched on how they ensure continuity of care and the follow-up practices that they provide for their patients. This is one of the biggest challenges in ensuring quality healthcare for ag workers because of their mobility. Even when they return to the same area year after year, continuity of care can be difficult, and managing those chronic conditions can be difficult. Changing locations multiple times a year can disrupt disease management and conditions like diabetes. And what we often see is that agricultural workers will only seek care when absolutely necessary, or may begin treatment but cannot continue because it's time to move again. When patients seek care in a new community, they may not remember the names of their medications they are prescribed, their dosages, or what protocols they were on. So all of these things come into play and are things to think about for continuity of care. And two great things to consider when addressing continuity of care, which Adelante is doing and Lucretia mentioned, is case management and health education for self-management. So we know proper case management can help prevent the disruption of chronic disease management and can prevent misdiagnosis that may occur in a new location that an ag worker patient is moving to, and can even reduce the risk that the patient might over-medicate or things like that. Self-management is key in controlling chronic illnesses as well. So it's important to educate our patients in order to help them understand what they can do to manage their illness and what information and records they may need to take with them as they travel to help set the stage for the best possible health outcomes for your ag worker patients. So now we're going to transition into sharing some resources with you all, which Lisa Miller will be sharing with us next.
Thanks, Katie. So the first resource we want to share with you all is the NCFH website. Our website has a wealth of information and resources available to you. So we have different tools and resources for health center staff, including fact sheets and research, our health center toolbox, and archived webinars. We also offer customized training and nine different learning collaboratives that allow health center staff to learn and engage with peers across the country. And we're going to have that link to that website on our chat in just a moment, and we'll go on to the next slide. NCFH also has specific patient information and resources on emerging issues. For example, COVID-19. There are two specific resource pages I'd like to point out. One is our COVID-19 resources for agricultural workers that includes patient education information that can be used for outreach, like handouts, flyers, and radio PSAs. The other is the COVID-19 resources for health centers and farm worker serving organizations, which includes resources for the workforce. Another great resource is our Call for Health, Una Voz para la Salud, helpline, which is available Monday through Friday for ag workers needing assistance in finding their local healthcare provider, their local community and migrant health center, or if they're in a remote area, another healthcare provider. And the information will also be linked in the chat here. And their hours of operation are 8:30 a.m. to 5:00 p.m. Central Time, Monday through Friday. And the other resource is our regional stream forums. NCFH works with partners in the East Coast and Midwest to host yearly regional stream forums that offer great educational learning opportunities for your staff. And those are coming up starting in February of this coming year. So we encourage you to check those out as well. And we'll go on to the next slide. The Farmworker Health Network works cooperatively with HRSA to provide training and technical assistance to over 1,000 community and migrant health centers throughout the U.S. The following training and technical assistance partners, or NTAPs, form the FHN, along with NCFH, and offer training and resources to health centers that serve the ag worker population. And they include Health Outreach Partners, MHP Salud, the National Association of Community Health Centers, MCN, Migrant Clinicians Network, Farmworker Justice, and NCFH. And we'll link in the chat as well to our page for more information on that. And we'll go on to the next slide, please. We also have 2 newsletters that we encourage you to sign up for. Our NCFH News is all news and information about migrant health. It comes out monthly, the first week of every month, and we have a link for that in the chat. And then our Boletín de Sol a Sol is also a monthly publication that is infectious disease specific and has a lot of great outreach information for you. So we encourage you to sign up for that as well. And then we're also on social media on Facebook, Twitter, Instagram, YouTube, and LinkedIn. And we encourage you to follow us on social media as well. And on the next slide, if you haven't signed up to join the Ag Worker Access Campaign, we have a QR code here where you can access the information. And we encourage you to support this initiative to increase the number of migratory and seasonal ag workers seen in health centers across the U.S. We'll go on to the next slide, please. Thank you all so much for joining us today. For those viewing the webinar on playback, this concludes today's webinar presentation. For those joining us live, please stay online and for our live Q&A and to provide some feedback on today's session.